This lecture is going to focus on lower extremity regional anesthesia techniques. The first block I'm going to discuss is the fascia iliaca nerve block. So the fascia iliaca nerve block is a very effective way to get the femoral nerve and the lateral femorocutaneous distributions. The bottom left, looking at the screen image, shows to the far left the sartorius muscle. In the middle bottom, the iliopsoas muscle, which is the iliacus and the psoas muscle fused to insert on the femur. The femoral nerve is the yellow structure. Then we have our femoral vessels and lymphatics to the right, and above the femoral nerve and the iliopsoas muscle is the fascia iliaca. This is a very thick connective tissue membrane that envelopes the muscle, and spread of local anesthesia below the fascia iliaca will spread laterally, superiorly to get the lateral femorocutaneous nerve, but also medially to get the anterior and posterior divisions of the femoral nerve. We can also see above the fascia iliaca is the fascia lata. You may have heard of a two-pop technique. It would be through the lata, iliaca, and inject. There are some osteotomes of the femoral head. There's the medial condyle osteotomes. There's the skin distribution of the lateral femorocutaneous nerve. There's the skin distribution of the saphenous nerve and femoral nerve. And all of these would be covered with the fascia iliaca nerve block. So what is the fascia iliaca block? It's blockade of the femoral nerve. 100% of the time you will get the femoral nerve. And the femoral nerve is the anterior and medial thigh, down to and including the medial knee. An anesthesia, a variable strip of skin on the medial leg, usually down below the medial malleolus. And the femoral nerve also contributes to the articular fibers of both the hip and knee. The lateral femorocutaneous nerve is the cutaneous innervation to the anterior lateral thigh. Now, the iliacus muscle is that large, flat muscle inside the ilium. It originates from the upper ilium and crest and sacrum in the iliolumbar ligaments. The iliacus joins with the lateral side of the psoas muscle to form the iliopsoas muscle. The iliopsoas exits the pelvis below the inguinal ligament, wraps around the proximal neck of the femur, and inserts into the lesser trochanter, acting as a hip flexor. Just a quick review of the lumbar plexus, it's the nerve roots from T12 to L5. The largest branch is the femoral nerve. 2, 3, and 4 is the femoral nerve. The fascial covering over the iliopsoas muscle is a thick covering known as the fascia iliaca. When you bring your needle through this fascia iliaca, it feels like a defined pop, almost like a needle is going through a piece of tinfoil. The lateral femorocutaneous nerve is a purely sensory nerve, and it's arising from L2 and 3 nerve roots. Sensation from the iliac crest down to the lateral portion of the thigh. The lateral femorocutaneous nerve emerges from the lumbar plexus, travels downward and lateral to the psoas muscle, and crosses the iliacus muscle deep to the iliacus fascia. The obturator nerves innervate a portion of the distal and medial thigh. And we'll also hear that there's posterior branches that go to the posterior capsule of the knee. They arise from L2, 3, and 4. The obturator nerves are sometimes involved in the fascia iliaca cutaneous block, but probably plays little role in postoperative pain relief for most surgeries of the hip and proximal femur. So I have our two images here, kind of showing you how the fascia iliaca covers the iliacus muscle, the iliopsoas muscle, the femoral nerve. Now, the lateral femorocutaneous nerve will eventually pierce the fascia iliaca and become external, but the idea is that the spread of local anesthesia will get it underneath the fascia iliaca. Also have a nice demonstration of the inguinal ligament and how the nerve and the muscles, the sartorius, are all coming from or below that ligament. So a little bit about technique. In the upper left, the yellow on the image is showing our potential or our hoped spread of local anesthesia, our local anesthetic solution, to get the lateral femorocutaneous nerve and the femoral nerve. And this is a large volume block. So when you do large volume, you have to use a lower concentration. So I'll typically use 0.25 ropivacaine, 0.25 bupivacaine, but even more dilute solutions of 0.125 bupivacaine may be effective. You want frequent aspiration, and you want to make sure you're not compressing the vessel with your probe while you aspirate, because you can have a false negative. Now there's two techniques to the fascia iliaca block. This first one is more complicated and involves a greater skill level. The second one is a very easy approach to the fascia iliaca nerve block. In the one demonstrated here, the probe position is as shown. In the bottom right image shows the ilium, which is the cortical bone on the bottom of the image, and then a flat striated muscle. That's the iliacus and the iliopsoas. Now above that is the fascia iliaca. So our needle is going to go between the fascia iliaca and the iliacus muscle. And we're going to lift up that fascia iliaca, and what's above the fascia iliaca in this view is cephalad is the internal oblique muscle, and caudad is the sartorius muscle. And they come together and are connected by the inguinal ligament, and that's called the bow tie sign. So you want to see your ASIS laterally, you move the probe medially, you see the iliacus laying over the ilium, fascia iliaca over the iliacus, the internal oblique and the sartorius forming a bow tie. And your needle will go through the sartorius, popping through the fascia iliaca, and your injection will be cephalad to have spread above the iliacus muscle, below the fascia iliaca, to get the lumbar plexus, L234, causing the femoral nerve, and the lateral femocutaneous nerve before it exits the fascia iliaca. This video demonstrates an in-plane approach with a 22 gauge 4-inch needle, blunt tip needle, coming through the sartorius muscle at about the level of the inguinal ligament. An injection is made after piercing the fascia iliaca, and spread of a local anesthetic solution spreads cephalad under the internal oblique and fascia iliaca to get the lateral femocutaneous nerve and the femoral nerve. So just to rehash the technique, we want to palpate the anterior superior iliac spine, and we want to put the probe over it, and we will see a bone that looks like a mountaintop coming right to the skin, because you can feel that your ASIS is very superficial. This is a landmark. You move the probe medially, and you will see the ilium drop down, and you will see the edge of the ilium with the iliacus muscle covering the ilium. And above that will be a bright band of iliacus fascia. You want to put color flow on to show that there are no vessels in your field, because if you're too medial, you will eventually approach the femoral vessels. So you quickly put the color flow on, make sure there's no color flow showing blood vessels, and you want to advance the needle in plane to cross the iliacus fascia, about midway across the bony edge of the ilium. And you'll feel a great pop. You'll see your needle tip puncture the fascia iliaca, and your solution will lift the fascia iliaca off the superficial layer of the iliacus muscle, and spread will form in superior direction. As you inject your local anesthesia, you will perform what's called a hydrodissection. Hydrodissection means that as you inject, you create what was a potential space into an actual space filled with local anesthesia. Now, as that space opens up, under direct visualization of an in-plane needle, you can advance your needle into your local anesthetic solution, and you will have excellent spread of your local anesthesia. Now, a more streamlined and, in all honesty, easier technique is the Nysora approach to the fascia iliaca nerve block. This proposition is just like a femoral nerve block, except it's a little more lateral. Your needle will come through the sartorius muscle and puncture the fascia iliaca, and you'll deposit your 40 to 50 mLs of dilute local anesthesia to cover both the medial spread getting the femoral nerve and lateral encephalad spread getting the lateral femocutaneous nerve. There's two images here, and on the upper left it shows a yellow arrow where your needle tip will project. So your needle will come through that sartorius muscle, it will pop through the fascia iliaca, and then you have to be careful to not advance your needle into the iliacus muscle, but instead hydrodissect or open up the plane between the fascia iliaca and the iliacus muscle. This spread shown on the right upper image, the blue spread, will go to the femoral nerve, and you'll get the anterior and posterior divisions of the femoral nerve, as well as cephalad and lateral to get the lateral femocutaneous nerve. 100% of the time, you will get your femoral nerve. And 80 to 100% of the time has been quoted that you will get your lateral femocutaneous nerve. The obturator nerve, which you would get with a traditional fascia iliaca nerve block, usually is not covered, but this is not too clinically significant. So this is just some more images showing the relevant anatomy, probe position, injection plane. Now the three images in the middle of the screen show when the probe is mostly medial, and that's your standard femoral nerve block right there. The middle image is the probe position where this block will be proceeded to. And the far left, if you kept sliding the probe laterally, eventually you would see the tensor fascia lata muscle or tendon, muscle and tendon, and the sartorius muscle. And underneath that is the iliacus muscle, and to the far right is your femoral nerve, your femoral vessels. In the upper right image, we get a nice view of our ilioinguinal ligament, our sartorius muscle that's cut away, the femoral nerve, the anterior and posterior divisions, as well as the femoral vessels and veins, the obturator nerve on the far right. You can also see in the upper left of the upper right image, the lateral femocutaneous nerve comes under the ilioinguinal ligament and under the fascia iliaca until eventually it pierces and becomes more superficial. The bottom left picture is showing the two-pop technique, which was a landmark technique, which I am not advocating for, but just to give you an idea of the anatomy. Okay, let's focus in on the sciatic nerve block. This image from Nysora gives a nice view on the left, looking at the screen, of the osteotomes. How does the sciatic nerve innervate the bone? The middle image has to do with what muscles are controlled by the sciatic nerve. And the far right, looking at the screen, is your dermatomes. Knowledge of all three are relevant for deciding which block to do for which surgery. So the sciatic nerve is very useful for foot and ankle surgery, below knee amputation, posterior compartment of the knee. This image is a fresh cadaver dissection I did, and I was amazed how even very proximal in the leg, the sciatic nerve can be teased apart into its two components, the tibial and common peroneal nerves. The L4 to S3 lumbar and sacral plexus. A sciatic nerve enters the pelvis along with the posterior cutaneous nerve of the thigh through the sciatic foramen deep to the piriformis muscle, and it passes between the greater trochanter and the ischial tuberosity and is superficial at the inferior border of the gluteus maximus muscle and courses down the posterior aspect of the thigh. Here's a nice look at the lumbar sacral plexus and their contributions from L4 to S3. There's a cutaneous look at the foot here on the looking at the screen on the left. We have our superficial peroneal nerve, the top of the foot, except for the web of the first two toes, very board relevant, is your deep peroneal nerve. Looking at the back of the foot, we have our calcaneal, plantar, and sural branches. And then the rest of the leg, we have our saphenous down to the medial mal, common peroneal, the femoral, and the obturator, as well as the lateral femocutaneous on the upper outer aspect of the thigh. So the first sciatic technique is called the Raj technique. The Raj technique can be performed patient either in Sims position or supine position, someone lifting the leg up. And basically, the midpoint between the greater trochanter and the ischial tuberosity we go straight in, and if the patient's frail, you'll be able to see this with a linear probe or the 8 to 12 megahertz frequency probe versus a curvilinear probe, which is a deeper structure probe. Once you get in the 5-6 centimeter range, you want to move to the curvilinear probe. But I have found in the patients that I use this on, like a frail elderly patient, I will be able to visualize the sciatic nerve at the midpoint between the greater trochanter and the ischial tuberosity. Now, these are two landmarks that are easy to feel. Feel your greater trochanter, feel your ischial tuberosity. In the midpoint is a big fat nerve there that you'll visualize and put local anesthesia around. Now, this technique is called the Labat sciatic block. This is a deeper block. It's something I did before ultrasound when I used a twitch monitor. We'd put the patient in this position, which is known as the Sims position. We'd draw a line with a marker from the PSIS to the greater trochanter, and at the midpoint, we would perpendicularly come down and then go straight until we had a twitch at 1.5 milliamps, dial down the current, make sure the twitch went away by 0.4 milliamps, and we would inject. With ultrasound and the other options to approach the sciatic nerve, I don't utilize this technique. Also, a technique I don't utilize but I'd like to teach here is called the anterior approach to the sciatic nerve. And the benefit here is the patient can be in the supine position. So usually with a curvilinear probe and a long needle, you will approach from the front to get the sciatic nerve. Okay, let's move on to the popliteal block. So here is a fresh cadaver dissection showing the common peroneal and posterior tibial nerves and their bifurcation. This is looking from the back of the leg. Now the popliteal block approaches the nerve. What does the nerve look like under ultrasound? What does it look like under microscope? So let's talk about the nerves. Here we show what's known as the paraneurium. So the common peroneal and the posterior tibial, they bifurcate. But they still have a surrounding, as you can see in this image. You can see after the bifurcation there's some stromal connective tissue. It's okay to pierce that and inject as long as you're not intraneural. So when we talk about peripheral nerve structure, we talk about the epineurium, the outer covering. We talk about the perineurium, surrounding the fascicles. And then we talk about the endoneurium, which is any non-neural element inside the fascicle. We don't want to enter any of those structures with our block needle. So it is important when you are doing a nerve block, as you start to inject, you never want to see your nerve swell. You never want to have pain on injection, also known as a paresthesia. You want to make sure you're not inside the nerve. So the image to the right shows the posterior tibial and the common peroneal nerve at the bifurcation. And the way I approach this block is I put my needle as shown in that image. And I will feel a pop as I go through the paraneurium. So the paraneurium is a fairly new term describing to the stromal or connective tissue sheath that surrounds the posterior tibial and the common peroneal nerve. So I will do this block. I will see where the nerve bifurcates. I will put my needle between the bifurcation. I will aspirate and inject 1 ml and make sure that the two nerves don't swell but instead spread apart. And that's why I'll put the majority of my local anesthesia. So I prefer to do the popliteal nerve block with the patient lateral. So typically what I'll do is have a draw sheet under the patient. I'll have the patient take their ipsilateral arm and reach for the contralateral side of the stretcher railing. And as they reach, I pull the draw sheet and it helps them get on their side very easily. I'll put a pillow between their knees and I will approach the sciatic nerve in this manner. So the image to the right shows our sciatic nerve coming down, shows the bifurcation, the tibial nerve, and the common peroneal nerve. The image in the upper left gives us a view of the common peroneal nerve and the tibial nerve, as well as the three compartments of the leg. So we have a medial compartment. The medial compartment contains our adductors. The anterior compartment contains the quadriceps and the extenders. And then we have the posterior compartment, which contains the biceps femoris, the semitendinosus, the semimembranosus. So take your fingers and feel both sides of your knee. On the lateral side, you'll feel the biceps muscle, the one singular tendon. And on the medial side, you'll feel the other part of your hamstrings, the semimembranosus and the tendinosus. In between this is where your sciatic nerve is running. The upper image in the middle gives an ultrasound image from a linear probe, high-frequency probe, of what the nerves look like on the screen. They're described as a honeycomb appearance. It's also possible to approach the popliteal nerve from the posterior approach by having the patient lying supine. And there are situations where you can't be, prone. There are situations where you can't be prone or lateral, like for example, if there's an X-fix on the patient. In that situation, you may keep the patient supine and prop the leg up on either a mayo or a group of pillows. And just to let you know too that a catheter sits very nice on the lateral aspect of the leg. And it is another option. This image shows a nerve block TUI needle and a 20 gauge polyamide catheter that will be paraneural, that will give local anesthesia over a number of days from an elastometric pump. So again, my approach is I will put the probe at the knee. And I will look for the popliteal artery. When I see the popliteal artery, which is easy to spot because it's pulsatile, and if I put color flow on, I'll see the change in color. The posterior popliteal artery will show you where the tibial nerve is because they're usually approximated. Once I spot tibial nerve, I will follow it proximally up the leg until I see the common peroneal joint. Now you want to move the probe fairly quickly, and you want to change your angle of inclination as you move. That means that you are kind of rocking the probe to get the best look at the nerve, because the nerve is a little bit like an accordion. And moving the probe just cephalad, you may not get the best view, so it's best to rock the probe to get the best view of the nerve. So I'll find the posterior tibial artery. That'll help me find the tibial nerve. I'll move proximally till I see the common peroneal join the tibial nerve to become the sciatic nerve. I'll come just distal until I have a nice bifurcation, two separate nerves. Then I'll put my 22 or 21 gauge blunt block needle through the paraneurium, but not intraneural, and inject enough local to surround both nerves. Now personally, I use a twitch monitor to show that before injection, I have no twitch at 0.4 milliamps, because the data confirms that having no twitch at 0.4 milliamps gives you some reassurance that you're not intraneural. So again, I'll see the bifurcation, I'll go through the paraneurium, I'll aspirate, have a negative aspiration, and I will inject 1 ml under low pressure. And if I see the two nerves spread apart in opposing directions, I will then put 5 ml aliquots until I see the common peroneal and the tibial nerve surrounded in what's known as the donut sign by local anesthesia. Now you could do this block higher in the femur, where you have one sciatic nerve. But think of the spread you would have to go to the center axons in that nerve. I've had occasions where I've completely surrounded the sciatic nerve at the mid-femur and had an incomplete block. And I believe that has to do with the spread or diffusion of the local anesthetic to the deepest parts of that nerve. So I've changed my technique to go at the bifurcation through the paraneurium, where I'll inject local anesthesia. Now, if I need a quick onset motor surgical anesthesia, I will use mepivacaine 1.5% with 1 cc of bicarb for every 9 cc's of local. This will make the block kicking quicker. Due to the pKa of mepivacaine, adding the base will lead to a higher unionized fraction of the mepivacaine. This will allow the mepivacaine to diffuse into the lipid-soluble membranes of the nerve. Although the ionized version of the local anesthetic is the active particle, it has to get in the nerve first, and to do that, we can speed the onset by increasing the unionized fraction. It's important to recognize you do not mix bicarb with bupivacaine, as it may precipitate. So this is something I only do with mepivacaine or lidocaine. A very common technique currently for knee surgery is to add an IPAC block, which is the infiltration between the popliteal artery and capsule of the knee block, in addition to an adductor canal block. So for years we would do a popliteal block for total knees, and we would have a foot drop postoperatively. This was a challenge because in 2% of valgus knees after total knee replacement, there's damage to the common peroneal nerve, and foot drop is surgical. So by performing the IPAC block, we can decrease the risk of a foot drop, but still get the fibers, or the innervation of the posterior knee joint, while sparing the main trunks of the tibial common peroneal nerves. So how do we do it? We put the patient supine in a frog leg position, preoperatively. We start the probe like we would an adductor canal block, and we find the superficial femoral artery, and we follow it through the adductor canal where it becomes posterior to be the posterior tibial artery. We see the medial femoral condyle, and we advance our needle in plane from lateral to medial between the popliteal vessels and the femoral condyle until we're 2 centimeters past the femoral artery. Now, there are cases of arterial damage from this block, so it is important to visualize your needle from start to finish and do not make contact with the vascular structures. Once we're 1 to 2 centimeters past the artery, we will withdraw and inject 3 ml aliquots for a total of 10 to 20 mLs to get all of these posterior knee joint fibers. Okay, let's move on to the femoral nerve block. When I was a new attending and a resident, we did a lot of femoral nerve blocks. But recently we've shifted away from femoral nerve block to the adductor canal block. I'm going to talk about it because the anatomy is important, and there are certain situations where you may utilize femoral nerve block. So there's a few images on the screen here, starting with the dermatomes at the left, our probe position, our needle position for an in-plane technique. The bottom view image I like because it shows how the femoral nerve really spreads out. The femoral nerve, which comes from L2, 3, and 4 of the lumbar plexus, then has anterior and posterior divisions. And those divisions really spread out. So if your block is performed too distal, you potentially will miss many of the fibers. So how do we prevent this? Is we move our probe proximal until the deep and superficial femoral arteries become the common femoral artery. You want to perform your femoral nerve block proximal to where the superficial and deep femoral arteries bifurcate. So you move your probe cephalad until you see one artery, then you move your probe laterally until you get your nice view of the femoral nerve. Once you're over the femoral nerve, you push hard and you change your angle of inclination, or you rock the probe axially until you get a beautiful view of the femoral nerve block, of the femoral nerve sitting on the iliacus muscle or iliopsoas muscle. Then your needle will come in plane through the skin and subcutaneous tissues, through the fascia lata. You'll feel a pop through the fascia iliaca. And then you'll be careful to aspirate and inject outside of the femoral nerve. You do not want spread inside of the nerve, as you may cause axonal disruption. We'll put enough local anesthesia to surround the femoral nerve, and that will give us complete 0 out of 5 quad strength. That means if a patient were to stand up, put weight on their leg, it will buckle and they could fall. So if a femoral nerve block is going to be proceeded with, you must educate the patient that they must wear a leg immobilizer and have assistance out of bed, as falls are very frequent. This block will give you 0 to 5 quadriceps, but it will also give you some femur coverage, including the medial condyle, including the saphenous nerve, and can be very effective for surgeries like quadricep tendon repair or total knee replacement. Now, this is not utilized much for total knee replacement anymore, as it is thought that the quadricep weakness can be avoided or minimized by performing an adductor canal nerve block. So just to reinforce, we have the bifurcation of the femoral artery into the superficial and deep femorals. We have the anterior divisions of the femoral nerve, which supply the motor fibers of the sartorius and the pectineus muscle. And then we have our posterior divisions, which descends as the femoral nerve to become the saphenous nerve. 3 images on the screen. I want to point out that if you're utilizing a twitch monitor with ultrasound, you want to see the patellar dance sign, which is the patella moving, not necessarily just sartorial twitch, because sartorial twitch can be more of the anterior divisions, and we want to make sure we get the posterior divisions, which are going to feed that medial knee. Femoral nerve block indications: injury on the anterior medial leg below the knee, repair of the quadriceps tendon, muscle biopsy, long saphenous vein stripping, postoperative femur and knee surgery, aka above knee amputation. The femoral nerve innervation, bone and articular innervation via the posterior division. The knee joint is anterior medial compartment. The hip joint, anterior compartment. Anterior and lateral part of the femur. The medial part of the ankle joint. Now let's talk about the femoral nerve block versus the femoral triangle block versus the adductor canal block. Now I just want to point out there's a lot of literature that has shown non-inferiority of the adductor canal block to the femoral block. In other words, you're not losing analgesia by performing an adductor canal block over a femoral nerve block. But what you're gaining, which was studied by Dr. Jager, is less quadricep weakness. So 100% of the time with a femoral nerve block, you will have a 0 out of 5 quad strength. With an adductor canal block, the data shows about 5% of people have quadricep weakness. So this means that quadricep weakness is possible with the adductor canal block. So the patient should be warned about it, and the discussion with the nurse about fall risk and walking with assistance should occur, but it's much less frequent. Now, for example, with a total knee replacement, the femoral nerve covers about 65% of the pain. And the fact that adductor canal block is non-inferior to femoral nerve blocks means that an adductor canal block should cover 65% of the analgesia after total knee replacement, and up to 85% analgesia for an ACL repair. That being said, for total knee replacement, there's still 35% of the pain. And this can be approached with your IPAC block and also the multimodal approach to pain management, which includes Tylenol, and Celebrex or Toradol, and intrathecal opioids and other options. All right, so let's take a deep dive into the adductor canal block. We have our patient supine. We have a sartorius muscle. We have our vastus medialis muscle and the adductors. In between all that is our saphenous nerve, our nerve to the vastus medialis, our femoral artery, and vein. The image on the far right middle has the sartorius muscle resected away. and gives you a look at what's inside the canal. The bottom right image shows a needle coming in plane from lateral to medial to put local anesthesia around the saphenous nerve and nerve to the vastus medialis. Just want to point out in the leg that there's 3 compartments of muscles: the posterior, medial, and anterior compartment. Medial compartment containing the adductors, anterior compartment containing the extenders of the lower leg, and the posterior compartment containing the flexors of the lower leg. This is an image with the sartorius muscle retracted, showing the saphenous nerve running with the superficial femoral artery. So the common femoral gives the deep and superficial femoral arteries. The suprafemoral artery runs down the leg under the sartorius before it goes through the adductor canal, through Hunter's canal, to become the popliteal artery behind the knee. This is an in-plane approach for an adductor canal block. This is a needle popping into the sartorius muscle, still inside the muscle. The block will not work at this location. Watch the needle tip as it exits the muscle, still inside the muscle, still inside the muscle, pop. When you have that pop and you inject, the needle is directly under the saphenous nerve and superficial femoral artery. I also want to point out there's the nerve to the vastus medialis, which is another branch off the femoral. This does have some sensory genicular branches that go to the knee, but also can result in some quadricep weakness. It's a demonstration of injecting 10 mLs of Indian ink dye. Will spread north and south quite a bit, so your exact location of the needle probably isn't all that important. The important thing is that the artery is directly deep to the sartorius muscle in the location that you do your block. The bottom right here just shows spread of dye injected at the mid-femur level, and how it really doesn't get up high enough to the femoral nerve proper, and this is why the quadricep weakness is minimized. Some relevant terminology: we have Scarpa's triangle. It's a femoral triangle that's high up in the leg, the apex of which is directed downward, and sides are formed by the sartorius on one side laterally and internally by the margin of adductor longus. Our adductor canal block is below this, and that brings us to Hunter's canal, or the adductor canal, the aponeurotic space between the posterior, medial, and anterior compartments of the leg, and that is covered by the sartorius muscle, and it contains the femoral artery, the vein, and the saphenous nerve. The adductor canal, the subsartorial canal, is a triangular in cross-section, and it's bounded by 4 muscles. The canal contains the femoral artery, the femoral vein, the posterior branch of the obturator nerve, and this will innervate the posterior capsule, and will be accomplished when you do a distal third adductor canal block on the leg. It extends from the upper anterior thigh, where the sartorius crosses the adductor longus, which is the apex of Scarpa's triangle, to the lower lateral third. 12 to 14 centimeters proximal to knee is the adductor hiatus. This is where the superficial femoral artery is going to dive through Hunter's canal to become the posterior tibial artery. The saphenous nerve is a branch of the femoral nerve. It's a sensory nerve. It innervates the medial side of the lower, albeit with significant interpatient variability. Follows the saphenous vein subcutaneously along the medial side of the knee to the lower leg. Now, the saphenous nerve in general can be blocked with the typical femoral nerve block. It can be transsartorially in the Hunter's canal. It can be proximally medial tibia at the level of the tibial tuberosity, or at the angle right above the medial malleolus. So this was a look at the lower extremity, ranging from our sciatic nerve blocks at the Labat technique, subgluteally, the Raj technique, popliteal, 6 centimeters above the knee, and IPAC, the fibers that innervate the posterior capsule at the knee. We also talked about our femoral nerve blocks and our blocks of the adductor canal in an attempt to cover the osteotomes, the dermatomes, and the musculature of the femoral nerve. If you have any questions, email me or call me. Talk to you soon.